I'm going to do a live Q&A about PMDD, premenstrual dysphoric disorder, and PMS, premenstrual syndrome. Now, I've done a YouTube already about these conditions, and I've also got a podcast, and I've done a combined YouTube with Dr. Hannah Ward, and also some women who have had experiences of PMDD. So there are other resources as well, but I get so many questions about it. And actually, it's a condition that is spoken about more, but not enough. It's talked about in medical circles, but still not enough. And for many years, I didn't really know how to adequately treat it. A lot of the guidelines are very outdated and they're not based on evidence. Sometimes there's conflicts with some of the authors as well. So we have to be really careful what we read. But actually, we need to know what it is and what can be done about it, because even the letters can cause some confusion. So PMS is premenstrual syndrome, which is actually basically saying it's associated with the symptoms that people have those few days before their periods. So many of us have had symptoms before our periods where we felt a bit low, a bit argumentative, a bit moody, just a bit joyless and flat. And then our period comes and we feel better, and then we forget about it until the next month. About 95% of women, so basically pretty much all women, will have some symptoms, and they really vary. Sometimes it can be very trivial, they don't last very long, but when they become more severe and troublesome, it can cause PMDD, premenstrual dysphoric disorder. Now, depends what you read about the criteria for PMDD, but and how do you define severe? What's severe for one woman is going to be different for another. And actually, how do we as doctors interpret whether someone's symptoms are severely affecting them or not? As a doctor, I strongly feel we should try and reduce suffering. So even someone with mild or less severe symptoms should still be entitled to as good and as an effective treatment as people with really severe symptoms. So it's very subjective. And this is part of the problem with these diagnoses of hormonal changes, is that there isn't a diagnostic test. And so far too often women are told that you're making it up, that it's in your mind, that you can't be having these symptoms because all your blood tests are normal. But actually what we need to do as clinicians is take very good, clear histories and look to see if there is a pattern with menstruation. So one of the reasons I developed the free Balance app is that people can monitor their symptoms very closely and with their periods as well. And if there is any pattern, then it is worth thinking, is it hormonal changes that are causing symptoms? And we know that some women are more sensitive than others to these hormonal changes that can occur. And it's important that they're picked up because there's a lot of suffering. Now, symptoms can be physical or psychological, sometimes a combination, but it's often the brain-related symptoms that can affect people the worst, because if you're low in your mood, if you've got poor memory, if you're tired, if you've got reduced concentration, if you're irritable or angry, then it will affect you probably at home, but maybe also at work as well. So it's having a big impact on people. Women with PMDD, we know, have increased incidence of suicidal thoughts. And some people I speak to have very, very dark, intrusive thoughts. And then their period comes and they feel completely different. It's like the difference between night and day. So I've got the chat open here I'm just about to open it on the YouTube, but I've also had quite a few questions on my Instagram. So I'm going to go for this first, and then for the Instagram. So I'm just opening it on my phone now. And then if you've got any questions, then you can just put them in the chat, and then I can have a look at them as well. So let me it's a live stream chat, so I can see there's a few questions, but I am going to open this first. Oh, hang on, sorry. Hang on, here we go. So, right, so there are quite a few questions. So I'm just going to whittle through as many as I can in the time allocated. So a girl, 16-year-old, has PMDD. What do you suggest treating for this? So it's one of those things that can happen with younger people as well. Because it's a hormonal imbalance, in my mind, a lot of treatment would be thinking about replacing hormones. Now, the thing is, there is a big difference, as many of you know, between synthetic hormones and natural hormones. Ideally, it would be thinking about the natural hormones first. Obviously, I'm only giving very general advice, but quite often we will just give some natural progesterone, maybe for those few days. Sometimes we give estradiol, and occasionally, not really for 16-year-olds, we would consider testosterone in people a bit older who have low testosterone and haven't improved optimally with progesterone. It's worth talking to your doctor or someone who understands hormones to go through the options. Another one, how do we approach the possibility of teenage daughter? In our clinic, we're only insured to see people over the age of 18, but increasingly I hear about a lot of women who are struggling. Now, with a contraceptive pill, it can often make symptoms worse. So you want to try and find hormones that have less negative effects than others, and some progestogens can be tolerated better than others, but it is worth talking to someone who understands. Is oral estrogen safe? Everyone's talking about it transdermal. So oral estradiol is safe. The big confusion has been with ethinyl estradiol, which is in the contraceptive pills, which is a chemical, synthetic type of estrogen, and we know is associated with some risks. Oral estradiol, actually, when you look at the data, doesn't seem to be associated with risks. There's a debate whether it's associated with clot, but if the risk is there, it's very small. And for some women, oral estradiol is incredibly well tolerated. Does HRT work or help for everyone on it a few years and not feeling benefits? It might be the dose type needs changes, or your symptoms might be not related to your hormones. Always feeling down and tired the week before period. I'm taking HRT, but it doesn't help. So some people who are on HRT, their dose actually might need to be changed for that week or so before periods, because if your own hormones are lower, then you might need more just to top up, because really the trick is to try and have a similar level of hormones throughout each day, so then you're not getting changes, because people with PMDD, the symptoms are often triggered with a change in hormone levels. So having the same amount, but when your own hormones reduce, you've got to match that deficit. So sometimes we do suggest and talk through with our patients about how to increase on those days. I have PMDD, I don't have children, I'm on HRT and I'm 36, should I have my ovaries removed? Now, increasingly I'm hearing from a lot of women who are having their ovaries removed because their consultant says, look, it's a hormonal problem, let's remove your ovaries, then you won't have your hormones and everything will be fine. Well, they have maybe three issues with that. Firstly, it's not just due to hormones, it's due to changing often, so changing levels in hormones. So our hormones also are very beneficial for our brain, our body, and every tissue and cell in our body. So if we suddenly remove the ovaries, age 36, you're really going to reduce the hormones in your body. And that can have effects with symptoms, but also for future health as well, increased risk of diseases. So if you are going to do that, then it's really important to think about having HRT, maybe and testosterone as well after the operation. But the third thing that I worry about is the hormones are not just made in our ovaries. They're made and synthesized in other areas of our brain. And I've seen people that have had their ovaries removed, they're still getting changes and symptoms because it's the way their brain is manufacturing these hormones. Like, we can't take our brain out. So the best thing is really to try and optimize hormones first before thinking about having something like ovaries removed. What are the physical symptoms less commonly known about? So they're the same as menopausal symptoms. So if you go onto the Free Balance app or you go onto my website and search symptoms, you'll see a lot of the commonest symptoms. We've listed about, I think it's 72 there. But a lot of physical symptoms like palpitations, skin changes, dry eyes, dry mouth, muscle and joint pains, itchy skin. All of these can be related to low hormones, especially before periods. Heard a PMDD case where ovaries have been removed at a very young age. Yes, and it is really sad, says this lady. Recommended hormones for borderline personality disorder, monthly suicidal. So a lot of women are mislabeled as having a personality disorder when it's related to their hormones. It's really important to think about hormones. Does having PMS mean that menopause will be difficult too. So often if people have PMS or PMDD during perimenopause, their symptoms can often be worse because it's the same, hormonal change. So it is really important to think about having your hormones balanced so that when your own hormones decline, when you become perimenopausal, you already know what you're like having natural hormones, the body identical hormones prescribed for you, and then the dose can be obviously changed. My daughter has got terrible PMS, awful long-lasting period. She has a coil. So we often do recommend a coil, like a Mirena coil or a J-Des, but we'll often give progesterone as well because the Mirena or J-Des is a synthetic progestogen. It only really works on the womb. It sometimes leaks into the bloodstream, but then it's only the synthetic progesterone. So having the natural progesterone on top will still stimulate those receptors and have the beneficial effects. How do you know when PMDD is turned into perimenopause? You often don't, but they're just labels for women. The most important thing, rather than having a label, is having the right treatment so you feel better. How can you still have PMDD symptoms while you're on the contraceptive pill? Well, the contraceptive pills, and I've done a YouTube about this, is all synthetic, so they block the receptors in the body, and so people do often have symptoms as well, especially if they have a pill-free week as well. So if people are having symptoms, we'll often maybe convert them to from the contraceptive pill with the synthetic hormones to the natural hormones, and then think about contraception as well. Using 400 milligrams cyclogest cyclically alongside the patch, spotting for 4 to 15 days. There's lots of reasons why people have spotting, so I can't be individualized here, but sometimes it can be due to the balance of hormones as well. So it's just worth seeing someone to get this checked. Can a 41-year-old woman take continuous HRT to treat PMDD? Yes, absolutely. There's no minimum age for having continuous HRT. If PMS is caused by progesterone deficiency, why feel women good? Why do women feel good in the first half of their cycle? It's not really, I don't think, it's not so much progesterone deficiency, it's more the changing in levels. And in the second half of the cycle, you get a big increase and then a big decline, and it's often the changing. So it's more about giving back a steady amount of hormones rather than it being due to a deficiency as such. Right, I've got some questions here, so I'm going to answer those. Thank you. I'm 36. Oh no, I think that was the same question before about having her ovaries removed. The ovaries always, they're important for us. They're organs. There's a reason we have them, not just for fertility. And there are other hormones that are made in our ovaries as well. So I would think really carefully of having ovaries removed. There has been a massive move for anyone that has a hysterectomy for other reasons, not related to PMDD, just have your ovaries moved as well, because then you won't get ovarian cancer. Well, we do that with no other organ in the body. We don't remove someone's testes so they don't get testicular cancer. We don't remove people's thyroid so they don't get thyroid cancer. So unless someone's got a really, really good indication for having their ovaries removed, then I would actually be really careful and consider other ways. And if you've got low ovarian reserve, so you've got low hormones being produced by your ovaries, then consider having them topped up. But you don't need to have your ovaries taken out for that. I'm 34, had premature menopause from childhood leukemia and bone marrow transplant, age 14. Oh, it's just flicked. Sorry, let me go back to that question. For 17 years, I was on Femiston 210. I don't know if there's another part for that. So Femiston is a type of natural estrogen, but it's also got synthetic progesterone, dydrogesterone in it, which is fine for some women. But some people find that's not enough, or they might find that they need testosterone as well. So if you're getting symptoms, especially as you're young as well, you really want to optimize your hormones for your future health. So it's worth seeing someone else. I have PMDD and was okay with estrogen and testosterone gel, but found Nutrigesta made symptoms worse. What proportion of women cope with the pessaries? I'm now afraid to try it. So it's really interesting, actually. So the pessary, when it's used rectally or vaginally, it gets absorbed straight into the bloodstream as the natural progesterone. We usually give cyclogest because it's made for the vagina or the rectum. Some people use Nutrigestin off license, but sometimes the sort of outer lining of the gel-filled capsule melts, and then people get quite a large spurt of progesterone, and it sort of, I don't know, maybe get a bit of a peak, and you don't want to. You want a gradual increase. So the cyclogest are often better absorbed. And it's very interesting because paradoxically, some women who don't respond well to a low level of or low dose of progesterone actually respond better to a higher dose. And sometimes we give 200 or 400 milligrams of cyclogest, maybe 2 or 3 times a day. Now, the half-life, so the time it lasts in the body, is very short. So trying it, people quite quickly know whether they're going to have a benefit or not. So a lot of patients try it and are a bit nervous, and then they go, wow, that's amazing, that's transformed my life. And Katrina Dalton, who did a lot of this amazing work in the 1960s and 70s, was using 1,000 milligrams of progesterone to women. But unfortunately, the medical establishment didn't like what she was doing, and so not many people carried on her work. But we've been reading her books and her papers, and it all makes sense, actually. So some people do need, but it's worth trying. And I always say to patients, if it doesn't help or you feel worse, it doesn't last long in the body, so it's worth sort of thinking about it and knowing that it won't last long if you feel worse. Tried HRT, and I am now 1.5 months in trying Drovelis and Vivil, still feeling bad. Any other supplements? So it's really important balancing hormones, but looking at some supplements can help, but it's really very individualized, so I'm careful about really suggesting supplements to an audience. Vitamin D obviously is important for lots of reasons. Some of the B-type vitamins can help with the metabolism of hormones, so it's often worth thinking about that. Really thinking about diet. You don't want to have big sugar cravings, which will put a pull on your insulin and your pancreas. So it's important to snack regularly, but have food that's healthy. So try to reduce processed foods as well. A lot of people with PMDD, even having a snack at night time. So Katrina Dawson used to talk about like a rice cake or something like that, but a banana, a piece of fruit can sometimes be helpful. So it is important to think about nutrition, exercise, and I know it's hard to exercise when you're not feeling great, but even a small amount of exercise, going out for a walk, can actually really help some of the mental health symptoms as well. What's the difference between HRT and natural hormones? Well, I often use the word natural, sort of body identical hormones, which is HRT, just because for many women, HRT is the synthetic hormones that have been used in these studies in the past, scaring us away from HRT. So describing them as natural body identical, hopefully is just showing people that they are the same as the hormones we produce when we're younger. 34, had leukemia at 14. Quality of life was horrendous till I started with your clinic this year. Is there a wider conversation happening with teenage adult oncology aftercare about hormones? I doubt it. I've reached out to many cancer charities and I haven't had a response. But if you do have any contacts with any of the cancer charities, then please get them to get in touch with me directly through my drlouisenewson.co.uk website or email address. It's just info@drlouisenewson.co.uk. So any charities that you have any links with, I would love to do more information, because a lot of women are not told anything about hormones when they've had leukemia or chemotherapy. I have PMDD and ADHD, had the marina coil fitted. I'm on the waiting list to have ovaries removed. Well, I would be really thinking carefully about your hormones, thinking about progesterone, thinking about, I know you've got marina coil, but natural progesterone, thinking about estradiol, maybe having your estradiol level done, thinking about having your testosterone level done. A lot of people with ADHD really improve when they have adequate testosterone as well. And just remember, if you're having your ovaries removed, you're still getting hormones produced elsewhere. So I would always try and balance and smooth out your hormones before thinking about any operation. I'm on Monjava. I've been told that HRT patches are going to be the best option for me. Do you agree? Not really. There isn't really any evidence about Monjava with HRT. I know one of the societies has produced some guidelines, but it's not based on any evidence. So then we have to individualise care. I'm taking cyclogest in the luteal, which is the second half of the cycle, 400 to 600 milligrams a day. Often find the follicular phase, so the beginning, difficult. Would I benefit from taking cyclogest continually? I have regular periods. You might do. Now, a lot of times with hormones, we just try because, they're only natural hormones. All they're doing is topping up your own hormones. It's very different for when I prescribe a drug like an antidepressant. That is a very synthetic chemical drug that isn't replacing anything that we produce naturally in our body. These hormones are just topping up and trying, and a lot of women are quite intuitive. If you think it's related to hormones, it probably is. So thinking about the taking it continually, there's absolutely no harm to do that. I had a 15 center myoma. I don't know what that means. Myometrioma, is it? Would you still recommend HRT for perimenopause? My doctor gives my progesterone and testosterone, but not estrogen. Not really don't really know why there's a reason why you can't have estrogen. A lot of people can have the natural estradiol, which is very different to the synthetic estrogen. I'm on HRT, both patches and tablets. I'm the 36-year-old. Oh, perfect. Okay, great. Thank you. Does waking up at 4 a.m. in luteal phase signal progesterone deficiency? It really varies actually, because progesterone doesn't last very long in the body. When it's taken orally, it can stimulate the GABA receptors and really help with sleep. Some people take it orally and vaginally or as a pessary, and that's possible as well. Like, a lot of these things are off-label, but there's a lot we do in medicine that's off-label, but we very much very individualized care as well. So it's worth talking to your doctor. Obviously, there's other reasons why people don't sleep, but our natural hormones interfere with serotonin as well. I'm on Locrin due to PMDD. Use estradiol. Oh, it keeps flipping around. Sorry. Estradiol and Eutrogestan. Still struggling with mood swings, fuzziness, lack of joy, and low libido. Certainly worth having your testosterone level done with your SHBG, sex hormone binding globulin. So if your ratio, the 300 index, is low, then it would be worth maybe thinking about testosterone. If you have your estradiol levels done and it's low, you might need to change the dose as well, especially if you're getting some cyclical changes. It sounds like it's probably related to your hormones. Is it worth trying to ask for a female gynae as the older male consultants just brush you off? You know, it's really sad, isn't it? I can't answer that because I see a lot of horrendous things that female doctors have told their patients, and sometimes they have a better experience with men, or vice versa. I don't know that it should really be gynecologists controlling women's hormones when hormones are made in our brain as well. So often it's better to speak to a GP who understands hormones. There is also not just thinking about having ovaries removed, but there's a big move that I've seen in patients and women that they're having Zoladex, so injections to stop their ovaries working really, so shutting down their ovaries as a treatment for PMDD. Now, the problem is with that is that the hormones are then completely switched off. It's giving people a chemical menopause, and if people are young, then they've got an increased risk of disease. And even if they're older, there's still an increased risk of diseases. And the ovaries can still push out hormones even in the 50s and 60s, even when periods have stopped. They're still active for many women. So there is a harm of giving Zoladex, and they're often horrendous side effects as well. So if someone is offering you Zoladex for your PMDD, the next question really in my mind should be, what about having add back hormones? Am I going to have estradiol, progesterone, testosterone added back or not? I had a hysterectomy. Can I still use HRT if things are normal after tests? So testing is quite unreliable, but if you've had a hysterectomy, you still can have progesterone. Lots of people think you can't have progesterone because it's just for the lining of the womb, but it works all around our body. So a lot of people we see who've had hysterectomy, or they've had or they've got a marinocoiling, they still have progesterone and they have benefits with it as well. I had a 6-something myoma fibroid. My doctor was hesitant to give me estrogen. Okay, so there is this sort of scare that estrogen can fuel fibroids and make them worse. In my clinical experience, and actually in others as well, it doesn't really do this. Some people have fibroids regardless of what you do. If you have adequate progesterone as well, then it's unlikely to stimulate the fibroid. And there are really beneficial effects of having estradiol in the body as well. You mentioned there could be other reasons for waking at 4 a.m. Oh gosh, there's lots of reasons. I have done a podcast about sleep. I'm sure I've done a YouTube about sleep, and there's a good article about sleep actually on my website. So I would have a look at that as well. So I think I've gone through all the questions. And I hope that's been helpful. It's always hard to give proper advice when I'm just answering questions, of course, but hopefully it's given you just a bit of confidence maybe to speak to your doctor, your healthcare professional, work out a plan that's right for you. And often with people with PMDD, the goalposts are changing because their own hormones are changing. So having the confidence sometimes to alter your dose, sometimes, especially if it's of the estrogen gel, especially as hormones fluctuate so quickly, then can be really, really transformational. And thinking about the the natural progesterone giving in different ways. So pessary. Some people, if they need the contraception, I would consider one that's got estradiol in rather than the ethinyl estradiol. And people still sometimes can have progesterone and testosterone with the contraceptive as well. Some people need antidepressants, but we used to really prescribe them more first line for PMDD, and some people still do, but I don't really see why you would give an antidepressant for a hormonal imbalance. It's not really treating the underlying cause. So I think, you can have hormones and antidepressants, but certainly if you are being offered antidepressants first line, I would, especially if you feel that you perhaps don't need them, I would really question that as well. So I hope that's been helpful. Thanks for those of you that have tuned in. And if you're watching it as a recording, then thanks for joining as well. And then let me know other topics that you want. We've got some lined up for the next few weeks, but if there are any specific topics you want, let me know. You can just put a comment on one of my Instagram posts or email me through the website. And look forward to speaking to you soon. Thank you.